So welcome everybody. Hello and welcome again to our PCC4U webinar today. We're hosting the webinar from QUT in Brisbane or Meanjin, which is on the Turrbal and Yagara country. We're just going to play a short acknowledgement to country video now. Thank you, Sharon.
QUT acknowledges the First Nations owners of the lands on where we gather today and pay our respects to the elders, laws, customs and creation spirits of this country. For thousands of years, the First Nations owners have gathered to share their knowledge and stories. We pay our respects to all Aboriginal and Torres Strait Islander peoples and acknowledge the important role they play within our communities. We recognise their long and continuing connection to country, the lands, winds and waters throughout Australia. We recognise that these lands have always been places of teaching, researching and learning.
We'd like to give you an opportunity to share with us in the chat today where you're coming from as an acknowledgement to country. And while you're doing that, I'd like to introduce ourselves. My name is Karen Wynn and I'm here today with my fellow learning and development colleague Sharon Wetzig, along with Kylie Ash, who is our National PCC4U, just waving there, Project Manager. So thank you very much for joining us. We're looking forward to sharing with you today the knowledge of two great speakers. Firstly, Dr. Pauline Gillen, who's a palliative care academic at Charles Sturt University, and Melanie Barlow, an academic simulation specialist at Australian Catholic University. Both will be sharing their work in relation to the use of simulation to teach communication and how this can improve palliative care. Firstly, it's my great pleasure to introduce Dr. Pauline Gillen to our webinar today. Thank you for joining us, Pauline.
Thank you. Thank you for having me. It's a lovely opportunity. Thank you.
Thank you. Dr. Pauline Gillen has a long career as a palliative care RN, working with and supporting many patients and their families. Pauline then applied her knowledge and skills to the world of academia, where she has completed her PhD and works to support and develop this knowledge in undergraduate nurses at Charles Sturt University. So thank you again for joining us. Can you just tell us a little bit about your work in palliative care and how that links to your current research in academia?
Okay. I guess like most nurses, I'm trusting we have a lot of nurses that are listening in today, and it may be other health professionals as well, but nurses are very well situated to be caring for people at the end of life and in palliative care. And I like most nurses, my career of caring for people at the end of life started when I started my undergraduate training as a student nurse in hospital training back then. It was back in the 80s. So it started off then, and then I ended up developing a great passion for palliative care because I started to see that we could actually, we could do better. And that's what led me to my applying the kind of education in academia, so to undergraduate nursing students, and led me to my PhD, which was developing simulation methods of healthcare. Developed them in a simulation for third-year elective at QUT for undergraduate nursing students, and in that I actually used two of the scenarios. Michelle was the first one, and we also used William was the other scenario we used, and so that was an exciting opportunity for students to start practicing some communication skills.
Yeah, you did touch on Michelle's story, and I'd like to ask you some questions about that in a moment. So just for some context for anybody who's listening who hasn't seen Michelle's story before, I'll show you on the website shortly where we can find that. But that story just follows the illness trajectory of a young mother who is diagnosed with metastatic breast cancer. Tell us about your process of using Michelle's story from the PCC4U resources and why you thought, or how it works well as a simulation.
Okay. So with Michelle's story, we started using Michelle in the tutorial. So the third-year elective unit that I was teaching into at QUT at the time, the last couple of years, actually had a component of, so that was online study, but it was a component of intensive school period where they had a couple of days face-to-face and students came in for the day. We had a lecture on symptom management, communication, all sorts of important strategies for palliative care. And Michelle's story featured very very closely within that. So because one of our big learning objectives in that unit was about communication, palliative care communication and difficult conversations. So Michelle was great because I started using Michelle in the tutorials, which gave the students opportunities. We were watching the videos where they had some questions and some group work to do in that. And the idea of that was to provide the background and the scene setting for then going in the afternoon to do the simulations where they would actually get to physically meet Michelle, who was a real person. A great opportunity to have that nice backdrop, some developmental background of her, some scene setting, and and applying what they learned in the tutorials and the lectures into the simulation. So it gave them a really good link for linking theory to practice. So that was probably one of the best things about them, is that the interactive videos that on Michelle really lends really nicely to that background, and the fact that she was a real person. When they met her in the simulations made a lot of difference to them, really, polishing their communication skills.
What were your key objectives for using Michelle as a case study?
The key objectives on this was a theme, I guess, across the whole of the undergraduate elective unit in palliative care, was about communication and really polishing communication and looking at psychological and psychosocial and spiritual aspects of care, and the Michelle scenario really lent itself very, very well to that. And the final objective there, I think, that also lent well from Michelle was symptom management and assessment. So because Michelle had some complex symptoms, like she was undergoing some chemotherapy and some radiotherapy, she had some really challenging symptoms, and that really gave us a good opportunity to address those in the scenario as well.
Can you discuss the power in using simulation to teach these concepts?
Simulation is very flexible. I find it's a very, very flexible mode of instruction and education for not only undergraduate nursing students but also for postgraduate, and it can be applied anywhere, even in situ in hospitals. And the scenario that we use with Michelle, we'd actually developed that for a clinic scenario, so that's a little bit of a different scenario than what we see often in simulations. So it was just that Michelle particularly lent itself to such flexibility. So we could have had Michelle, I could have developed Michelle in a hospital situation, but it just lent itself so nicely for where she was at in the clinic situation. So particularly like a palliative care clinic scenario where she'd come in talking about some of the symptoms she was experiencing, but also some of the issues she was experiencing in her home life with her husband and children, because she had small children. So simulation in this instance, because we were using standardized patients in particular, it gave us a really good, it gave a very, very strong link from theory to practice. Students could really appreciate that this was a situation that they might come across when they become registered nurses, or even in their clinical placements during, even for the last few months of their training. So it's just a very powerful medium to be able to link that theory to practice. And
I like what you said about the flexibility, that you could use her story in a clinical setting, in a hospital setting, in an outpatient setting, because of the psychosocial care needs that she has. Can you share with us some of the informal feedback you received from the students who participated in the immersive experience? How did they find it?
They actually, I only had small groups of students, but they loved it. The students' feedback was overwhelmingly positive. Like, they come out of the simulation and they overwhelmingly said, "Oh, we didn't expect to meet a real person." And I think that was probably because throughout their 3-year degree at QUT is that they'd had lots and lots of simulation, but they'd never experienced the real person, the standardized patients. They'd always had high fidelity mannequins or the low fidelity mannequins. So for them, that was to me the key for them experiencing such, to them, the feedback that I got, that they really enjoyed the experience and that they learn a lot from it. And the research that I was doing was just quantitative research. So it was just, post-simulation surveys that the students were doing, but they overwhelmingly showed that they strongly agree that the teaching strategies used were very effective.
What would be your advice to other academics wanting to use simulation to teach palliative care communication?
I would recommend that you know, if you've got a real passion for it, I would recommend that you do, because it's one of those areas. Well, when I researched it for my PhD and even for this research project that I'm finishing off now, there really isn't a lot of literature out there on, so these projects aren't being done a lot. So it is such it does give students the opportunity to practice this communication then, you know, before they have to have it in real life. So I would encourage people to do it. But PCC4U has those wonderful resources to use as a starting point. Those videos, you know, they're a wonderful, I guess they gave me the little spark, I think, to then go, right, I can use this and develop it further. For me as an academic, I needed some particulars that weren't necessarily provided in the background, but that's good, because I had that starting point and I just developed that background from that. But if you've got that spark and you've got this passion, you can see a deficit or a gap in clinical practice, then this is what we need as clinicians, is we need to have students prepared, and we need to have, you know, even registered nurses. We don't always come across these situations. So I think it would be a nice refresher. And if you want to use standardized patients, I think that, to me, my experience of using high fidelity mannequins and standardized patients, and you do need to make sure that you're supported. That's one of the things that we had to make sure of, is that students knew where to go to get some counselling or some support, or, you know, if they needed some extra time with me.
Good advice. Well, thank you so much for sharing that experience. Thank you again. And Pauline will stay on the line at the end of our webinar today if anyone has any questions about that methodology that she's used. So thank you so much, Pauline.
Thank you, Karen.
And I see that Sharon and Kylie have popped into the chat there, the website where you can find Michelle's story. I'll just share my screen now and just show you. So this is our landing page for the PCC4U website, if you haven't opened that link already. And you'll find here, if you come up to learning modules and come down, you'll come down to here to communicating with people affected by life-limiting illnesses. So it's module 2. One of our core modules. If you click on that, you'll be able to open straight up to Michelle's story. So if you scroll down, these are all the videos that Pauline was discussing before. So there's quite a lot of YouTube videos there, and they follow the trajectory of Michelle. So you get to meet Michelle, get to meet her family, get to see the emotions that she goes through in relation to her diagnosis and the trajectory of her illness. Down here, you can see it has the aims and objectives of the module as well. So you can work out where they may align with what you're wanting to teach with your methodology. It also includes a PDF writable interactive workbooks, and they can reflect upon what they're seeing and reading and listening to in the workbook. And also, we've had really good feedback from students that all the videos include we have the transcripts, I should say, to all the YouTube videos here as well. So that's had good feedback. The students like to be able to read through the scripting of the video along with watching it as well. And this is just the breakdown of what's inside each module. So you may be able to pick and mix depending on what you're wanting to do. Is that what you did, Pauline? You sort of work through what you needed based on what was available?
Yeah, we had quite a few of the videos we showed in the tutorials. We used quite a lot for the scene setting. So some of the tutorials were focusing on communication, others were focusing on the psychosocial, spiritual aspects of care. And there's some beautiful videos there where they just really address those so nicely.
What I'll also show with you and share with you quickly is the simulation guide. If you're wanting to do some faculty development for your staff who are delivering sim, or if you're new to sim yourself, or you just wanted to go through some simulation theory, perhaps it's been a little while since you've looked at some things, we have a simulation guide found here on our LMS, so our learning management system. Once you come into our learning management system and you've registered, you'll have access to our learning guides and our learning modules. So you'll find the simulation guide under the Educator Community Hub here. And then when you come down, you'll see Guide to Simulation for Educators. So this can be a good resource, especially if you're bringing on new faculty who will be running your simulations and who may or may not know some of the ins and outs of simulation, especially around psychological safety. So when you go into the guide, you'll see, I'll just share it on screen there, that it's broken into many different chapters on different things that might be relevant to some faculty development that you may have. So it's in there, you can work your way through it. There's no order to having to do the chapters. It does scaffold, but you could come in and out of a chapter and have a little read, and it includes podcasts and some interviews from simulation specialists from around the world. Well, thank you everybody for completing the poll. We've just got it up there. Sharon has the results up there. So everybody is mostly in agreement that obviously that we need to use simulation to teach our students the best we can. And then not everybody does use that, but I'm hoping that today, if you're here, you're interested in perhaps embedding that into your curriculum. I'll introduce you to our next speaker. I had the privilege recently of sitting down and the pleasure of sitting down with Melanie Barlow. She's a simulation specialist and an academic lead for simulation at ACU here in Brisbane. Melanie is going to share with us her advice on the approaches to take to facilitate the development of confident communication skills in our undergraduates. Good morning, Mel. Thank you so much for joining us today.
Thanks, Karen. Good to be here.
Thank you so much. What I'd really like to talk to you today is about the importance of developing really strong communication skills in our undergraduate students so we can better prepare them for the complexities and the difficult conversations they may have in the future with palliative care patients and their families.
You know, like any educator, I started in clinical education and then they said, and by the way, here's a mannequin.
Yeah. Yes, always. Yeah.
Good luck. And basically I learnt by trial and error. So I think I've made every error known to man.
Yeah.
And then it got to about 2010, 2011, and I was a manager, education manager in a different organization. And they said, oh, here's some money to build a sim center.
Great.
And I'm like, oh, I really should get some formal training.
Yes. Yeah.
And it was getting the formal training at big aha moments for me. And so I am all for faculty development programs, etc. And that then basically since then I've been in simulation full time. I became a director of a sim center, and so that has led me to my current role at ACU in the Faculty of Health. And yeah, in the last 6 years I've been trying to finish my PhD. Yes. Almost there. Yeah, and that's specifically in healthcare communication.
Wonderful. Yeah.
So particularly speaking up conversations and the role the receiver plays in those conversations.
It's great to hear from someone who's learnt along the way, who's experienced different levels of training, and who's also really looking at communication as a important part of our education, and not always just the skill part that sometimes we do get a bit caught up in.
I am a strong advocate. I think, you know, when people talk about simulation, they think it has to be all this high fidelity, you know, bells and whistles, but really stripping it all back. And yeah, simulation is an ideal methodology for healthcare communication. Kind of conversational rehearsal. There are now programs out there where people can do independent, deliberate practice at home using either virtual reality, AI programs. There are some great programs out there where students can practice and practice by themselves. They then come into the classroom.
Yes, yeah.
And we can, you know, peer-to-peer role modeling, conversation rehearsal.
Yes.
It's really simple, but really effective. And then setting them up for success when, you know, we want to do the bigger immersive simulations or bring in, you know, the paid actors. And so, yeah, there's a big tendency to jump to let's get actors in and do all the bells and whistles when we haven't actually set them up for that.
Yeah, that's
there's
right.
a whole array of things we can do really simply and really effectively before we get there. You know, we have these speaking up algorithms. So say it like this when you want to speak up, you know, or they're in different conversational contexts, whatever the conversation is, there are suggested ways of framing that conversation. And I think our students get so, you know, and even I've seen this in qualified clinicians, so focused on the skill and saying it the right way. Yeah. That we lose context of this is a conversation. And so if I say the speaking up rubric, woohoo, my job's done. And when in actual fact, that's just the opener to the conversation. I think we need to remind our learners that, yes, this is here to help you, but don't try and purely focus on the skill. Just, you know, listen. And I think the more we can help them rehearse, you know, they can find their more kind of authentic voice and be willing to go a little bit off script, because that's what, you know, in listening to the person, that's what's required for that situation. Right. Obviously, in undergraduate, they need to build on the skills. And so we need to do simulations where we can give them deliberate feedback on the skill and on the actions.
Yes, yeah.
But then we also need to put them in situations and use other sim methodologies where we delve deeper.
Yes.
So you said that, but this was the response. They'll assess and hear that the other person, you know, elements of emotional needs, like, you know, they were stressed or they were frustrated, but they don't outwardly acknowledge that.
Oh, okay.
And so what they do is, well, I'm feeling uncomfortable. What's my comfort zone? Doing tasks, right?
Looking busy.
A good nurse is time efficient and ticks off the things and gets it done. But that's not what the other person needs in that moment. Knowing not only what to say, but we need to start teaching people how to receive that message. You know, how do we manage ourselves? How do we know what to say back? You know, and it was really interesting because, like, I'm guessing with end of life conversations or withdrawal of treatment conversations, just like speaking up, they're framed always as difficult or challenging conversations. And so one of my studies was in sim. And where the receivers didn't do well is when the conversation wasn't difficult and it wasn't challenging. And they were like, we're so used to speaking up being challenging that when it wasn't, I didn't know what to say or how to act.
So not enough cues coming from the patient themselves, is that why?
Yeah. And so I think we need to be careful of how we frame and label these conversations. Yeah, I think, yes, practice, different levels of practice. Part of this conversation, yes, it's not just about the skill, but how do we teach our students to manage emotions? You know, how to support the patient, but also themselves, because our emotions get in the way of our listening, gets in the way of what we're willing to say. And so, yes, the learning objectives might be around framing the conversation, but also an objective might be, well, how can we teach the students in that moment to also, you know, manage those other nuances. So there's a paper called Sim Zones, and it's a framework, and it's developed by Chris Russon out of Boston. And I picked this up and read this when I was, you know, director of Sim in a hospital environment, and went, oh, that's nice, and put it down. And then it wasn't until I came into this role where I was thinking, you know, managing simulation across 16 different disciplines, then across a year, and then across a whole 3-year curriculum. How do we then formulate a faculty development plan to support that? And then on top of that, a strategy, right? And so I picked this paper up again, and it was like, oh,
there it is.
Aha moment. And for some reason, it just this time reading it clicked.
Meant something.
And so what Chris and Peter Weinstock did was, there's 4 zones. And so it's really helpful tool to decide, what are my learning objectives? What am I trying to achieve? Okay, where does that sit? And therefore I'll use this type of simulation. Zone 0 is student independent deliberate practice. So that might be the virtual reality, AI conversational tools. They're completely by themselves doing deliberate practice. Zone 1 is then still deliberate practice, but now with facilitated feedback. So this is when they come in probably to the lab, they do some role playing, conversational rehearsal. More likely it's peer-to-peer, with your facilitator wandering around giving some feedback. And so this kind of still skill-based, so we're kind of giving feedback more on actions rather than deep diving. Zone 2, then we start building it up and putting it together. So this is where you might bring in your standardized or simulated patients, whether they're actors or, so we're kind of upping the ante of authenticity. You know, we put it in a bigger context. So it's not just the elements of the conversation, it's the conversation in a bigger context, like a clinical context. There you would start, debriefing more on the rationales and the thought processes behind what they were choosing to do in those moments. Zone 3, bringing teams together for rehearsal. And zone 4 is like clinical placement.
Yes, yeah. So putting
and
all together.
It doesn't sound like that simulation, but what I would love to see is we use those immersive debriefing, cognitive frame methodologies into clinical placement, and we train our facilitators.
That's right, yeah.
To how to have that. And so for me, I've seen it time and time again. A student does a competency, they pass that conversation skill in the lab, and then they go out. Yeah. And they can't do it. And then our immediate go-to is quick fix. I'm going to make them go back and do the competency. But they can already do the skill. They've shown us that. Right. Yeah. But something's getting in the way. And so by saying, I noticed in that moment you were doing this. Oh, well, it's the first time I've had that with a real patient, and the emotions overtook me and I didn't know how to manage, and da-da-da-da. So that's a very different learning need. And so this method really helps distill what is it you're trying to do. Keep your learning objectives really 3 max in any kind of simulation.
Agree.
So yes, Sim Zones by Chris Reeson. It is written for hospital-based simulation. Yes, yeah. And so it is a bit different in academic undergraduate training. Chris and I are going back and we are rewriting Sim Zones for academic training. Yeah. At universities, we do pre-briefing particularly well. Sure. Yeah. So I think we think pre-briefing is the spiel we do just before the sim. And in actual fact, it starts way back. Yes. When the students get the unit outline. So any communication in relation to that activity, that's part of the briefing. Yes. For that activity. But often I've seen that messaging isn't consistent. Sure. Okay. And so students are coming, having heard mixed messaging about that activity, to really establish setting students up for that activity in consideration of psychological safety. Being aware that briefing starts way back in the first, touch point of that unit and that activity. And then the pre-briefing is just before. Yeah, that's right. The activity itself. And so that whole thing contributes to psychological safety. Yeah. That activity. I'm sure you've covered this before, but saying it's a safe environment doesn't make it a safe environment. No, absolutely. Yeah, the students have to feel it. And that's so doing a well thought out pre-brief and being consistent as a facilitator, walking the talk. Yes, is make or break for that activity. And I think too, what I've seen is really well intended, but jumping straight to zone 2. Yeah. Where, I've seen in one discipline where they'll show a video of a conversation and talk about it in the tute. Yeah. But the student doesn't actually rehearse it. They watch it and discuss it. And then the next time they do that conversation for real, it's with a paid actor who's fully in the moment. Even my heart rate just went up. And so we haven't scaffolded that learning.
We really are setting a student up to fail if we jump too quickly, and then they're going to run away not only from simulation experiences, but they're also going to run away from that communication opportunities they can have with patients and maybe stay at that task level. And it could take some years for them to get to that communication level that we are hoping they could get to a bit sooner.
Yeah, just keep it simple, and simple is effective. And reduce the number of learning objectives you're trying to achieve. And the other thing too, and this is just a personal bent, the term non-technical and soft skills I'm guilty. Personally does my head in. It's only really since I've done my study that I've gone, man, like this isn't soft, this is really hard. And it's not non-technical, it's technical, and it's a skill, and it requires deliberate practice like any technical skill does.
And maybe changing that frame of how we think as education providers then changes how much effort we're putting into teaching it, simulating it, and providing materials around it for the student to learn. So no, thank you so much. I think your experience in simulation has been wonderful to be able to apply a lens to what we're doing, what we've done, and then also just being in the undergraduate space and seeing the difficulties, pathways you're taking there to, achieve greatness in your students with communication and confidence. No, thank you so much. It's been lovely to talk to you.
Yeah, thank you so much for having me. And good luck with all your simulations. I think, it's a wonderful thing you're doing, bringing it to light and talking about it.
Thank you, everybody. I hope you enjoyed those words from Mel, who's working really hard in the simulation space at university there to improve the communication skills in our undergraduates and to scaffold things as appropriately as possible to develop confidence in our undergraduates before they hit the real world. Any questions for Pauline before we do our summary today? Any questions about the methodology, processes, student outcomes?
Hi, Pauline. It's Alison from the University of Adelaide in the nursing school down here. I'm just wondering if you have used any of your simulations in a multidisciplinary setting as yet?
Mm-hmm. Okay, that's great. Thanks, Alison. Nice to meet you. From Adelaide, lovely to meet you. I've done quite a bit of simulation prior to moving to QUT. I was at UNE before there. I got involved with a small team. So I had social work colleague, we had a medical colleague, and we had a pharmacy colleague, and we did a very immersive simulation day where we had all four of our professions together, and we did a scenario where it was based on a clinical experience that I had as a palliative care nurse visiting a patient at home who did not have a advanced care directive, and she took sick and the ambulance arrived to her and full resuscitation. Unfortunately, she didn't have this advanced care planning, so she ended up in ICU, intubated, very, very sick, didn't have a very nice end of life, and we used that. Developed a scenario from that. It was great because we had it was quite challenging for students, but there were fourth year meds, third year nursing students, lots like Mel had said, lots of preparation, lots of scaffolding leading up to this. And this was a voluntary day where we did some research on. So that was probably that's the only time I've actually used interprofessional simulation, but it was a really exciting immersive simulation, and the students really stepped up, and it was a little bit challenging for them, but they stepped up and we provided lots of supports for them, and we managed to get one paper out of that. So that was very, very, to me it was a very exciting opportunity, and we had lots of great feedback from all of the health professionals, gave them a clearer understanding of what other people's roles were at the end of life. So we put it out there as I guess we sold it as a simulation, because a lot of students want to do simulation. We sold it as an opportunity for them to step up in their roles and to actually work really physically with other professions, because we ran two scenarios at the same time. And we managed to step students throughout, and so we ended up getting we had two at the same time. We ran it twice, so we had 4 per bedside, which was perfect. So we had each of health professional, so small numbers. So I guess that's not, it's challenging if you want to do that for big numbers. I guess you'd be looking at maybe doing video, filming it and videoing, but then that's also tricky too.
And Alison, it's Kylie here. I can give you some further information about some work that we did with another university and with large numbers of students, social work, exercise physiology, nutrition, dietetics, and pharmacy. And that was using patient simulated actors as well. So it can be done. And I think one of the key parts, and Pauline touched on it, was that you get that beautiful development of interprofessional capabilities as well as palliative care, communication knowledge and skills also. So there's some good opportunities there, and a number of the resources. We've got the IPL case scenario that I know has been used also in that sort of setting. So I can follow up on that if you'd like.
Thank you, Kylie. That would be great.
So that concludes our webinar for today, and we'll share with you some take-home messages in a moment. We'd also ask if you can complete the webinar poll that we'll share in the chat just now. That would be very useful for us as well. Reminder that our next webinar will be on October the 18th. And I'd like to give a really big thank you to Pauline for joining us today and sharing your knowledge on this really important topic, along with a big thank you to Mel Barlow for her interview as well and for joining me earlier. So thank you again to everyone for joining us today. We're happy to stay on the line if you do have any questions that have popped up. But if not, thank you, and we'll see you at the next webinar.